Good morning, everybody. This is the MDS UK Patient Support Group patient meeting for the Repair MDS clinical trial. And great big warm welcome to everybody on the call today. So we have today speakers from Warwick, from the different parts of the Repair MDS clinical trial. And while we'll ask for a tiny little round of introductions from all our speakers. We have Dr. Manoj Raghavan, Dr. Stephen Jenkins, Dr. Farhad Kanim, Dr. Chris Bunce, and some of the staff of the Repair MDS clinical trial. So can I start with, on the top of my screen, Dr. Steve Jenkins.
Thank you, Sophie. Hello, everyone. Thank you very much for coming to the meeting. I'm Dr. Steve Jenkins. I'm a consultant haematologist based at Russell's Hall in the West Midlands, but I'm attached to the Warwick Clinical Trials Unit, and I'm co-chief clinical investigator for the Repair MDS trial, some aspects of which we'll be running through today.
Thank you very much
for coming.
Thank you. Manoj.
Hi, I'm Manoj Raghavan. I'm another consultant haematologist, and I'm a senior lecturer at the University of Birmingham and University Hospital, Birmingham, Queen Elizabeth. And I've been involved in treating MDS patients for over 10 years. I specialise in myeloid malignancy, so I'm also the co-chief investigator with Steve. We work very much together on this.
Lovely, thank you very much. Farhad.
Hi, everybody. It's lovely to meet you. So I'm a scientist and have been working in blood cancer for more than 20 years. And we developed one of the treatment arms that is part of Repair MDS. So today I will be telling you a little bit about the science behind it.
Lovely. Thank you very much. Chris, please.
Hi, likewise, very nice to meet you all. My name's Chris Bunce. I think my big role here is that I was lucky enough to be able to work with the funders to actually sort of raise the money that was put aside to fund this, which we then all applied for together. But I'm also involved in, as a scientist, I'm also involved in overseeing the parallel science that will occur alongside the trial, sorry.
Lovely. Thank you so much. Let's start with the first presentation, and that would be Dr. Manoj Raghavan.
Thanks very much, Sophie. I recognise we're running about 15 minutes over, but I'll try and do a little catch up, but I think probably we'll try and take our time, especially as we're trying to introduce the subjects. I know people will be of various stages through their disease, some very newly diagnosed, some of you are very old hands at this. But I'll try and take you through some of the treatments. And we're going to specifically do low-risk MDS because that's what this trial is about. Next slide, please. There we go. So MDS has been described now for well over 100 years. And the reason it's called what it's called is because we're looking at the myeloid blood cells, which makes your red cells, white cell, neutrophils, and platelets mostly, and hence myelodysplasia and dysplasia because they look abnormal. That's what dysplasia actually means. And you can see some pictures there which show you it's difficult for you to probably to understand how abnormal those cells actually are, but they don't look right when we look at them down in a microscope. The likes of Steve and I do this on a regular basis. And they're all lots of different types. It's a syndrome rather than a disease, as it's called, because there are a lot of different types and they have a different prognosis, and it extends from one spectrum to another, really. They are all cancers, and it's a difficult definition these days with cancer, but one can think of cancers as one cell that takes over, that's grown out of control, although that's not the full definition probably of cancer, but definitely for MDS, that works. And the way it affects things is, as in this slide, with the red cells being low, the neutrophil counts often being low, and the platelet count being low. And we define the classification comes about depending on how many of those lines are actually down. So if you've got one line down, we say it's single lineage. If you've got more than one of the cells that are low, we call it multi-lineage. We also look at the aspect of blast cells. So these are the immature cells, which we all have. You need the immature cells to make the mature ones. But they can be relatively low, which is relatively normal, or they can be increased as the disease progresses. And you've got enough of them that can sometimes be attributed as being acute myeloid leukemia, which is why it can head off in that direction. The other important thing about this is because it's a cancer, you have damage to your genes, you have damage to your DNA, and that's true of every cancer. So it does not just MDS here. But one of the things with MDS and blood cancers in general is that we can look much more easily than a lot of other cancers. So we've got a good idea of the abnormalities that are there. And those abnormalities can be attributed as either good or intermediate or being quite bad or poor. We think of these in terms of two aspects. One is the chromosome. So we all have 46 chromosomes and then an X and a Y chromosome, or an X and an X chromosome. And those chromosomes can be damaged. So you can see those down the microscope. You can see, sorry, could we go back one? Thank you. And you can see the damage when you grow the cells. But we also have at a gene level abnormalities as well. And the genes, these are the programs that we have within us to make us. And they can go wrong in cancer as well. And they define how the cancer goes and how the MDS goes. And so if you have individual damage of individual genes, you won't see that on the chromosomes. They're far too small, as you can kind of see by that diagram. But they are there, and we have ways of measuring that. And in the last sort of 5-10 years, we've been much better at trying to do so. So it's changed things in many ways. So we think of things in terms of genes and also in terms of chromosomes, in terms of the genetic damage. And this isn't inherited. This isn't something you'll pass on to your children or you got from your mother or father. This is damage you've got over your lifetime. Next slide, please. So this is kind of just trying to point out what the importance of genetics is in cancer and in MDS in particular. So as I said, all cancers have damage to their DNA, and that comes out as mutations of one kind or another. And they give the characteristics of the cancer. So they might make the cells grow a lot. That's what the sustained proliferative signaling you see in the green at the top, for example, makes out. Or they can make the cells live for a very long time, which they've got to do if they're a cancer. And I'll talk a little bit more about telomeres in the next slide. So that'll become quite important. But all of these kind of aspects that you see in this circle are important for a cancer to actually work. And that's how they actually start to grow out of control and actually cause harm to yourself. So each of those mutations will do something along those lines. Next slide, please. Okay. The genetics and those other attributes all define what the risk of your MDS is. As you can kind of see here, most patients are actually low risk. So that big hump you can see on L is low risk and the VL is very low risk. And then it goes up. There are moderate risk, ML, MH, high risk and very high risk. We're just going to talk about the ones in the moderate and low risk arms. But you can see that's the vast majority of patients. The ironic thing about that is those are the patients who have the least treatments available to them. But these are the ones that we want to focus on, and these are the ones that most of you will have, really. And next slide, please. You'll see that the very low risk and the low risk patients live for years. If you think that the average patient with MDS is probably in their 70s, that means, you know, for the very low risk people, half of the patients live to around about 8-10 years. And that means that very much, you know, you may well get into your 80s or even longer. Whereas some of the high risk are much poorer. So even at the intermediate stage, we're talking about patients living 3 or 4 years. Now, clearly, if you're younger, that's a big deal. But for the older patients, this may or may not be the cardinal thing that affects your life expectancy. But clearly, it has a lot of symptoms and it's really important. Next slide, please. So on to treatment. How do we manage these low and intermediate risk type patients? So you can think of it in two aspects. One is just supportive care or conservative management. So these are treatments that are really trying to improve your symptoms. They're not going to change the disease. They don't really change very much about the way the disease behaves, but they do help you in one way or another. The other side is, how do you actually tackle the MDS itself? And how do you actually improve the natural history, if you like, of how the disease is going to progress? So supportive care, I'm going to talk about some growth factors. Some of you will have heard of these, things like erythropoietin, EPO, or GCSF, which is growth factor for neutrophils. Transfusions, which a lot of you will be on. Sorry, a moment. Apologies. Iron chelation. So a lot of you have transfusions, will get a lot of iron in those transfusions, and that can cause issues. And there are certain aspects we can give tablets or injections for that as well. In terms of treatments for MDS, what we're talking about, there are specific types of MDS that have treatments, like MDS with del5q. So this is loss of a little bit of the 5q chromosome. This can be treated with lenalidomide. For those with ring sideroblasts, there is a treatment out there which isn't available in the UK called luspatercept. There are specific types of MDS where you have a low amount of bone marrow, sort of almost akin to aplastic anemia, and there are some immune treatments that be given there. And for younger patients or fitter patients, certainly, there is the possibility of giving an allogeneic stem cell transplant, which we do much more often in high-risk disease, but sometimes do for low-risk disease. Next slide, please. There. I'm going to talk really briefly on this, and I'm going to dwell on this at all. So for an allogeneic stem cell transplant, this is the only cure, but it's got to be worth it because there are considerable risks with this. I mean, when I tell patients, I say, yes, you can die from this, so it's got to be appropriate. But just in terms, so therefore, it generally gets thought about for patients of a younger age, but it's not an absolute. You've got to have significant symptoms to make it worth your while. So you're getting a lot of problems, either from infections or bleeding or from transfusions. There are very occasional patients who have got bad genetics, but they don't quite come up as a low-risk MDS. They come up as a low risk for one reason or another. And if other therapies fail sometimes, for example, lenalidomide in some cases, or specific types. Next slide, please. So I'm going to talk a little bit about growth factors, EPO, GCSF, and some growth factors for platelets. So I'll start off with EPO, which is for red cells. So this is a hormone we all have. It's made in your kidneys, stimulates your bone marrow cells. You can see there's a little receptor there, which is where the EPO attaches to, that is on your red cells and on your red cell precursors, that makes them grow. And a lot of you may have heard about this. This is the stuff that the Tour de France guys have all been cheating with for years. But it stimulates despite it, whether you've got MDS or you haven't got MDS. Next slide, please. It does work for a lot of people, but one of the criteria is that you shouldn't be making too much EPO already, because if you are, it's not going to really do anything. It tends not to work if you're having a lot of transfusions. Bit of a catch-22, that one. The ones who need it the most, it won't work for. And it stops working. Sometimes, I have patients it stops after just a few months, sometimes for a few years, but for a lot of patients, it will stop working. Next slide. So infections, back one. Or we on thrombocytopenia? Okay. Yeah, thrombocytopenia. So low platelets and bleeding. So what do we do for those patients? Well, standard, which many of you who do have bleeding problems will be that you have platelet transfusion. And we only give those really if you're bleeding. It's not sort of, you can't give those just as a prophylaxis to try and stop things from happening. One thing you can do to try and stop things is a drug called tranexamic acid, which makes your platelets stickier. So that's a drug that is often used in these kind of situations. There are two growth factors that can be, or sort of TPO is the growth factor, and there are two drugs that can act on that growth factor receptor. One is called romiplostim, the other one is called L-trombopag.
You've got your 2-minute warning, Manoj. 2 minutes.
I'll be as quick as I can. So one of those is an injection, the other one's a tablet. So they'll stimulate you to make platelets. And the current British guidelines, which I was part of writing, did suggest that this is really useful, but it is difficult to get hold of in reality. So it is a problem. Next slide, please. We can do the same with white blood cells. So patients who are getting infections, there's a growth factor called GCSF, either filgrastim or lenagrastim, and it will stimulate your immature cells to become mature neutrophils. So any cells that can do it will do it. The other thing you can do is give antibiotics to try and prevent things, but we generally do that for the high-risk guys rather than for low risk. It's not really recommended because beyond long-term antibiotics can have problems in its own right. Next slide, please. So there are clinical trials. There are not many of them. And this is not just UK. This is looking across the world at the kind of things that we've got in low-risk MDS. So things that any of you might have found out there. I mean, some of these I don't know very much about. The NLRP3 inhibitor is just a phase 1 trial. So phase 1 means first in man, effectively. So they're just trying it on people and seeing what happens from a safety aspect and whether anything impacts. So this is something to do with inflammation, which often occurs in patients with MDS. Imetelstat is a telomerase inhibitor. I'll talk about telomeres in a later slide. And there are some trials in myelofibrosis and in MDS as well. Roxadustat is something to do, it acts on renal-induced anemia, so it's kind of acting on the EPO pathways, trying to make you get more EPO or effects like that. Luspatercept, which I mentioned, there is a study in the UK randomizing it against EPO to see which one is better.
Time, Manoj.
And there's this other drug called PKR. They're only in a few centres. They're not widespread. You have to know where they are. And, you know, for most patients, this is, you know, how do you travel to these things? It's really difficult. Next slide. So this is the summary. There are few treatments. They often stop working. Even worldwide, there are not many studies available for patients with MDS. So the idea of Repair MDS is to try and make this available, make a trial available to patients on a widespread basis that might be effective. Next slide. That's just a summary of kind of where we are at the moment in terms of the guidelines. Thanks very much.
Thank you, Manoj.
I want to take questions afterwards. Is that right, Sophie, I guess?
Yes, I think
okay.
We'll do that.
Okay.
And you're welcome, everybody, to put in some questions in the chat already, and we can go back to those when we have the question and answer sessions. Steve, can I ask you to take the next?
Thank you, Sophie. Thank you, Manoj. Thank you, everyone, for attending. This is what I'm going to talk about in the next few minutes. Just Repair MDS, sort of broad trial overview, and what you might expect as a Repair MDS patient. As mentioned, I'm a consultant haematologist in West Midlands and attached to the Warwick Clinical Trials Unit. So,
sorry.
Thank you. Thanks, Sophie. Why clinical trials are important and good for all. So just a broad comment of this. Clinical trials are the cornerstone of modern medicine. We deal in science and evidence and data. The evidence which is born out of clinical trials, it guides us as clinicians, it guides modern medicine, and nearly, you know, all that clinical evidence comes out of clinical trials. And I've just put in a little quote there by Richard Feynman, who was actually a physicist, American physicist, and he's talking about physics and science more broadly, but I think it's equally applicable to clinical medicine, and it applies there. It doesn't matter how beautiful your theory is, it doesn't matter how smart you are, if it doesn't agree with experiment, it's wrong. And that's the same in clinical medicine. It may look good, the theory may be excellent, but if it doesn't give the results you want, it's wrong. It doesn't advance. Next slide, please, Sophie. So who benefits from clinical trials? Most importantly, and then I'm sure there'll be many patients on the call here, the individual patient benefits from a clinical trial, because participants in any clinical trial have better outcomes compared to those who do not participate. There's very good evidence for this, that if you participate in the clinical trial, whatever that is in the whole field of medicine, you will do better than someone who doesn't. So why is that? Well, undoubtedly one aspect is they get earlier access to treatments or medicines that subsequently emerge as the standard of care. They do work. They do work and they get incorporated into clinical practice, but you've accessed that earlier than others before it becomes that standard. Also, by participating in clinical trial, to a degree, you have to be engaged. You undoubtedly become better informed, both as a patient and as the families surrounding that patient. You tend to have closer follow-up with medical teams as protocols dictate, as compared to standard of care, because there's more assessments. You're assessing whether there is benefit or indeed side effect or harm from any new intervention. And similarly, you have more frequent reviews with the trials nursing team as well. And there's a clear protocol for the physicians, the clinicians who are treating you and the nurses who are managing you on how to treat and manage you through whatever that disease may be. There is the confounding factor, though, of this aspect that people who participate in clinical trials do better than those who don't, because you, by definition, all trials have inclusion and exclusion criteria, and you tend to get a slightly fitter and slightly less comorbid population are able to enter the clinical trial, and therefore, by definition, persons who don't enter tend to be slightly more comorbid and less fitter. But there's also future patients. So the individual patient benefits, and that's the most important thing. But also, it shouldn't be forgotten, future patients benefit, because from those clinical trials, the proof of benefit, the acceptability of toxicities is accrued, and those new treatments then become folded into the standard of care and are then incorporated into guidelines. Next slide, please, Sophie. So who else? Medical and nursing teams. We benefit. The nursing team benefits. You get early familiarization with medicines and treatments before they become that standard of care. And as mentioned, there's a clear protocol on how to follow and manage patients in respect to that intervention. The institution that's participating in the clinical trial benefits. There tends to be better outcomes overall in clinical trials. It attracts staff who want to participate in clinical trials and emerging treatments. It attracts patients. Patients often want to access, understandably, what may turn out to be a better treatment. And then there's, in various ways, enhanced incomes, even if they're an academic trial, which is sponsored by a university or academic institution. There's still internal money within the NHS that follows that patient and that trial. And then also, even more broadly than that, the broader healthcare economy, you get closer links with academic institutions, closer links with industry, and more enhanced income for the economy as a whole. Next slide, please, Sophie. So, Repair MDS, repurpose drugs to improve hematological responses in myelodysplastic syndromes. We're very excited to have this trial open and offer it to the patients. As Manoj has highlighted in his earlier talk, there's a paucity of treatment options for patients with low or even intermediate low MDS. And once you've gone through EPO, and even EPO might not be suitable for all. So just to sort of break some of these terminologies down, because I'm we may well have quite a spectrum of persons on the call. A clinical trial, that's an observation and treatment of actual patients. It's not a theoretical or laboratory study. It's how this works in clinical practice. And this helps doctors understand how best to treat illnesses. Repair is open, an open trial, as opposed to a blinded or closed trial, where us as doctors and nurses and pharmacists, the investigators, and you or your relatives as patients and participants know which treatment arm, what treatment you've been allocated and are receiving. It's not blinded. It's phase 2. This means it's a new quote unquote medicine, and it's been tested on a larger group of people with a condition. But as we'll be going to highlight, these are actually repurposed drugs that we are familiar with anyway, as they have other conditions where they're already licensed to treat. And this provides a better idea of short-term effects, both beneficial and potential screening for toxicity or drawbacks. Next slide, please, Sophie. So it's randomized. So the treatment you received will be decided randomly by a randomizing computer with the Warwick Clinical Trials Unit. Us as clinicians and you as the patient, we determine that the trial may be suitable for you, discuss whether you're eligible for it, and you have to be consented and happy to enter into the trial. But you as the patient, nor us as the treating clinician, can quote unquote choose what arm you get within the trial. That is randomly allocated to try to remove bias, so we can determine statistically and scientifically, are these treatments truly of benefit. And that randomization happens in a one-to-one manner, so the overall number of patients in each arm is equally balanced. It's prospective, so we assess the patient at their current condition as you present to us, or maybe known to us in our clinic, and you as an individual, and therefore in the trial as a population. And we then deliver the intervention, and we see if that we derive a benefit or a change following that intervention. So it's looking forward into the future. Next slide, please, Sophie. And these are repurposed medications that I touched upon. So these are existing drugs already approved for human use. They've been around for decades and we're familiar with them. There's existing extensive data on their dosages, their side effect profiles, etc. And what we're doing is we're identifying another disease. So back again, Sophie, thanks. Another disease, in this place, lower risk MDS, and seeing if these drugs could potentially be a benefit. We tested through the clinical trials to confirm, do they have that benefit? This is opposed to brand new medications. These can take approximately 10 years from initial discovery to make it into the marketplace as a licensed drug. The clinical trial component of that journey can take 6 to 7 years. And then also, because of that duration, that time, and the expense involved in that, many rarer diseases are now recognized as orphan diseases due to lack of incentive for pharma to develop new drugs. And although MDS is well recognized and plenty of persons suffer from it, it is not as common as other cancers. Next slide, please, Sophie. So who can participate? Well, it's patients with very low risk or intermediate risk MDS. That is an IPSR score of 3.5 or less. And we calculate that based on your cytopenias, the appearance of your bone marrow in terms of primitive cells, and your cytogenetic profile. But in addition to that, you have to have cytopenias, so be anemic, platelet with a hemoglobin less than 100, platelets less than 100, and a history of bleeding or neutrophils less than 1, and a history of infection. In addition to this, you have had no response to ESAs, which is exogenous EPO, which Manoj was talking about earlier, or you've had ESAs and you've ceased to respond to them, or you're predicated not to respond to ESAs by current UK guidelines, i.e. you're making plenty of EPO yourselves, and you have to be reasonably mobile, ECOG of 3 or less. But the vast majority of our patients are in that performance category. Next slide, please, Sophie. You cannot participate. This isn't exhaustive, but these are some of the more pertinent exclusion criteria that are within the trial. Patients with poor renal function, and we have a renal sort of cutoff, patients with abnormal liver function, and then probably one of the most pertinent exclusions is patients who are receiving statins. And between 40 and 50% of patients in their 70s, 40-50% of the population rather, of patients within their 70s are receiving some form of statin. Okay, but you are only excluded if you're receiving the statin for a secondary prophylaxis. That means that you've had a cardiovascular or cerebrovascular event prior. You've had a previous heart attack, you've had a previous stroke, and the statin is to prevent you having a second event. So patients who are receiving statins for primary prophylaxis, so you've never had an event, heart attack, stroke, etc., but are nevertheless on a statin, you can participate within the trial. You have to withhold the statin for the duration of the trial medication. So you as a patient,
2 minutes,
clinician,
Steve.
Thanks, Beth. You as a clinician, you as a patient have to be comfortable with that decision, but we can talk more about that facet of the trial. Patients who are on warfarin, though if you're on a DOAC, some of these neuroanticoagulants, apixaban, rivaroxaban can be included. But if you've had a history of DVT and or PE, you can't. Previous cytotoxic treatments for MDS, but we've included azacitidine. Unfortunately, ladies of childbearing potential cannot be included, though that isn't usually particularly applicable to our population. Men with known current or prior prostate cancer, or participation in another IMP trial within the last 90 days. Next slide, please, Sophie. So how do I participate? Have a conversation with your consultant hematologist. If you have a diagnosis of confirmed or suspected myelodysplasia, have the conversation. We currently have 14 centres open. I appreciate that means that many people are not near a centre open, but we do have 20 to 30 sites that will open in total, and sites will usually gladly accept patients for referral from other nearby hospitals. But again, it's a matter of then the logistics of that for an individual patient in a site. So as I say, you can be referred on to an open site. So what happens if I want to participate in Repair? You discuss the trial with your consultant hematologist. You may well require referral to an open trial centre. If you're apparently eligible, you receive a PIL, a patient information leaflet, to read more about the trial. If the consultant, the PI we call that, who's in charge of the trial at your hospital, confirms you're eligible, you enter what we call a baseline period, baseline assessment period. You'll be asked to read and sign a consent document, and you'll be entered into the main trial. There's a separate consent for the bolt-on science, where we take additional samples for some basic science work.
You're at time.
And then, then we have a minimum of 28 days, potentially up to 16 weeks, where we have to gather your data in respect to transfusions and full blood counts. And then, next slide, please, Sophie. And how many more slides have I got now? A few.
Carry on, Steve. I think it's important.
Okay. Can you get me back to where we were? Thanks, Sophie. Okay, so next one. So within the baseline assessment period, what happens? Well, we need 16 weeks of data in respect to full blood count and transfusion history. Many of you will be known to a department anyway, so that could be collected retrospectively from your notes from your clinical record. But if not, if you're new patient, then we do need that 16 weeks. So there is a period where we gather that, but it can be a blend or a combination of the two, retrospectively and prospectively. And we do some other tests in there. We do a bone marrow because it's vital we confirm you have a diagnosis of MDS and the particular subtype of it. We do a liver and spleen ultrasound scan, so that's just doesn't involve radiation or anything, and we do ECG and some other baseline assessment blood tests as well. Next slide, please, Sophie. So within the baseline assessment period, furthermore, we confirm the eligibility for randomization. So you have to have MDS on your bone marrow with an appropriately low IPSSR score, acceptable renal and liver function, a normal ultrasound liver and spleen, acceptable ECG, and that's 16 weeks of data. Then you're randomized, randomly allocated to either VBAP or danazol, the two arms of the trial. Next slide, please. So after randomization, your consultant will prescribe your allocated treatment and explain the allocated treatment. And as mentioned, if you're already on statin for primary prevention of cardiovascular disease, that would have to pause for the duration of the trial medication. You'll receive a patient diary to record and as a reminder of your trial medication, the dosage and the frequency. You'll also have a quality of life questionnaire, which we then repeat quarterly throughout the year. And initially, you'll have an outpatient appointment with your consultant every 2 weeks for the first 16 weeks with blood tests at that juncture. That may be more than some of you routinely have, but there are some patients who need that frequency of assessment anyway. But then that'll extend out to monthly for the remainder of the year. Next slide, please, Sophie. So as mentioned, we have initial fortnightly visits, but there's the medications in both arms are incremented up, provided they're tolerated both clinically by you as a patient and biochemically on the blood tests that you have done. There's 5 stages within VBAP to get to the full dose, as it were. Within danazol, there's 3 stages. If there's side effects, doses of the medications may be withheld or may be held at the existing stage or actually paused and withheld, depending on the nature of that side effect. From 16 weeks onwards, visits extend to 4 weekly, and a full treatment period is 52 weeks. Blood product support continues as is clinically indicated throughout that time frame. Next slide, please, Sophie. Samples while on trial treatment. This is the response evaluation period after you're randomized whilst you're on the medications. So standard bloods every 2 weeks for 16 weeks, then every 4 weeks, the remainder of the 52-week marrow. We do ask for further bone marrow schedule at 24 weeks and at the end of the year, the 52-week point, but a trephine is not required within that. On a danazol arm, you do have to have a further liver and spleen ultrasound scan at the end of the year. And there is bolt-on peripheral blood samples that are taken monthly. And with those marrows, there's also bolt-on samples taken on those marrows at the approximate 6 months and at the end of the year. From patients who consent only, you can go into the trial without consenting to the bolt-on science. We would like you to do so, but obviously that's at your discretion. Next slide, please, Sophie. What happens after the 52 weeks of trial medication? Well, within the current framework as the trial currently stands, the trial medication ceases. However, if you tolerated the treatment well and you have had some benefit, and you and your consultant feel that there's been benefit, your consultant would need to seek and obtain agreement from your local medicines governance to continue to prescribe the medication, quote unquote, off trial. But these are repurposed drugs. They're not particularly expensive drugs in the schema of medications, but as I say, that would depend on your consultant and their local governance structures. However, we are hoping that one or both arms of the trial will show benefit and be tolerated, and there is the potential for a phase 3 trial would follow on from Repair, and phase 2 participants would provisionally be eligible to enter any subsequent phase 3 trial with one or both arms potentially in it. Next slide, please, Sophie. Speeding up. How will we tell whether one or both arms has worked? Well, patients, you effectively serve as your own control. Instead of comparing the medicine to a placebo, we compare it to your condition, your pre-treatment condition, that 16 weeks of data, and we see how your parameters change after the medications are commenced. But we'll focus on the following parameters: your hemoglobin, your platelets, your neutrophils, and the number of blood transfusions you have. We'll then compare the hematological parameters for all the participants in each arm overall and compare that back to before they started the trial treatments. We do not currently know if taking part in the study will help you personally, but there is a chance it may improve your blood counts, reduce your need for transfusions, and therefore frequency of your visits to hospital. Next slide, please, Sophie. Could my treatment or care change during the trial? Yes, depending how you tolerate the treatments. Adjustments you have been made, but you will not change trial treatment arm as such. If there are modifications to the protocol due to the standard review processes that go on through all clinical trials, that may change your management with that in that arm of the trial. Next slide, please, Sophie. And who can I discuss matters with regarding? Well, as we mentioned, primarily your consultant is looking after your care. In addition, your hematology nurses or clinical nurse specialists or your trial nursing team. And remember, there is no obligation to remain within the trial. If you don't wish to continue for any reason, standard care would continue as usual on the direction of your consultant hematologist, whether you don't go in or whether you go in and then subsequently come out of the trial. We would clarify the reasons why you had to cease the trial. So just, I think we're approaching the end of my slide set. Trial news and publications, we'll analyse the trial data and we'll publish them in high quality peer-reviewed journals, which will signpost to both our investigators and participants. And there's further information available in respect to the trial on the Repair website and the trials website listed there. And it's been subject to all standard stringent NHS reviews, ethics committee, regulatory approval MHRA, and the health research body of the NHR, as well as patient and public involvement with MDS UK. And we've also been reviewed by our generous funder, Blood Cancer UK. I think, is that it now, Sophie? Thank you. Any questions for the end? Because I've overrun.
Thank you very much, Steve. So again, put any questions in the chat for the time being, and I will now ask Manoj to talk about the danazol arm of the trial.
I'll try and be. We're a little behind. I'll try and be as brief as you can. We'll try, mainly because there are lots of questions, and I don't want people to be left out. Right. So danazol. Why are we using this drug? So next slide, please. So I'm going to start off explaining a little bit about these things called telomeres, which sit on the end of a chromosome. You can see I like genetics, so that's what I spoke about before. These are bits of DNA that sit on the end. They cap the end of your chromosomes, and the reason you need them is you don't want your chromosomes falling apart. You don't want them joining together with things they shouldn't. You don't want the ends to shorten too much, otherwise you'll lose the genes on the end. So these protect the ends, basically. And this is a problem with age for all of us. As we get older, our telomeres are going to get shorter, and your cells replicate over years and years and years, and the ends disappear. So you have these enzymes that put something back again, that make it longer. So senescence that you see written there is basically aging. So the telomere, as you see, gets shorter, and these telomerases, these enzymes, sit on the end and they make it longer once more. So they're pretty important with regard to how you might potentially age. And one of the things we know about them is that if you get mutations in these, and there are some people that do, you get bone marrow failure, you can get forms of MDS and even AML. Next slide, please. So this is just a quick picture just to show you what it looks like. So you've got these codes on the end that are basically the cap, that's your telomere. And you have this cap, which is this sheltering complex, which basically protects the end, and then the enzyme on the end that extends the end to try and stop you eating into the part where the actual genes actually are, that's what the whole idea is. Okay, next slide, please. So why is that so important for the blood system in particular? You make billions of cells every day. All of us do, regardless whether you've got MDS or not, for that matter. And these cells are going to lose, as you age, as these cells replicate, they're going to lose the ends of their telomeres. So if you've got a problem with those telomeres, then you are really going to get into problem, particularly for cells that rapidly divide, and your blood cells are probably some of the most rapidly dividing cells in your body. So less telomeres will cause the stem cells, which is where all the cells come from. So we have these things called stem cells or hematopoietic stem cells, the blood stem cells, that are where all the rest of the cells come from. And these are the ones that if they age, then you're in trouble, because those are where all your blood comes from. And if you have fewer of them, because they've aged and become unstable and been lost, then you'll get bone marrow failure. And that can lead to MDS or AML eventually, or sometimes aplastic anemia too. Next slide, please. So here's some pictures just to show you what really happens in MDS with telomeres. So patients with sort of relatively stable MDS have telomeres on the end, and you can see them there. So these are the red dots, they're labeled up. We know what the codes are, and you're able to do it. As the disease progresses, so your blood counts start dropping, then what we find is that the telomeres are shortened. And that's what you see in the next slide in C. Now, one of the things with cancers is that actually they try and get the telomeres back again because they want to grow. They want to keep going. So actually the telomeres coming back again can often be a late progression sign in MDS, or it certainly lead on to AML. Next slide, please. So is it important? Do patients with MDS and have short telomeres do worse than ones with long telomeres? And the answer seems to be, from some studies, yes. So this is a study that looked at about 80 patients, mostly treated with just supportive care. They didn't have chemotherapy. They had a combination of patients with a low and high risk disease. But in general, the short telomeres, what you can see on the graph, lived less long than the ones with long telomeres. So this gives us an indication that doing something about telomeres might be important. Next slide, please. We can also look at mice models with mice that have short telomeres. And you look at the descendants, as the descendants of the mice grow, each of them get even shorter telomeres, and they get more and more DNA damage. So as I said, these are responsible for keeping your chromosomes together, and that's where the damage will start to occur. And what they were cleverly able to do in this particular case was that they could look at the bone marrow of the mice that had abnormal bone marrow and weren't making good blood counts, but they were able to re-express the telomerase, so actually get it back to normal again. And the bone marrow started to look normal. So now we know that maybe shortened telomeres is a lead up to MDS, and getting it back again might improve your blood counts or certainly improve the bone marrow. So these both suggestions for that. Next slide, please. So this is kind of our model for how things might work. So this is a particularly looking at a model. So I said genetics are important in MDS, and in this particular types of mice, they've lost a particular gene or half of their genes with a particular gene called MIBL2. That's not particularly relevant. But what I want to get across to you is that these patients have damaged their DNA and their stem cells. That's what you see on the left of this diagram. And if you lose that, how slow that DNA damage response is, because you've got to try and repair everything, because otherwise your cells won't come back together again. The more you lose the telomeres and the more DNA damage you get, the more that you're going to get MDS. So this is sort of a lead in, really. You get damage to your telomeres, you get DNA damage, and that leads you to get MDS. That's really what I want you to get from this diagram, which is a little bit complicated, I realize. Next slide, please. So, danazol, what is it? Why is that relevant? This is it. It's been around for ages, 1963, so why now, really? Next slide, please. So it's used mostly for patients who are, it's used in gynecology, really. It's a hormone. That's where it's come from. But it's been known in hematology that it does improve blood counts for some patients who have anemia for one reason or another. One of the diseases is called pure red cell aplasia. I'm not going to detail that. But this was a study for those patients that I said had problems with their telomeres, that had genetic problems with their telomeres, are born that way, that when you gave them danazol, their blood count got better. And so the first graph you see there is that after 12 months, you can see a rise in the hemoglobin. The one doesn't show that. So the black ones are the patients had a low hemoglobin to begin with. Doesn't come out quite. The grey ones are the ones that are all the other patients. So they came out with, they may have had a reasonably good hemoglobin even to begin with. But the ones you can see in black are the ones to follow. So you can see their hemoglobin actually improved. And then they stopped the danazol, and you can see there's a drop. Not only that, it worked for hemoglobin, it also worked for neutrophils, and it certainly seemed to work for platelets as well. So this is an indication. These aren't patients with MDS, they've got telomere problems. So the question is now, is this relevant for MDS? Next slide, please. This is just to say that their telomeres did actually get longer. It wasn't just the fact that their blood counts got longer and it wasn't that reason, but actually both of these slides show that the patients got longer telomeres. Their telomere length at 2 years was actually longer, more than 96 base. They lost less than 96 base pairs, and those are the changes from baseline. Next slide, please. Skip this. There are some studies looking at danazol in MDS, but they're all done retrospectively. In other words, it's looking backwards. It's not done looking forwards. You might lose some data if you do it that way. You remember the guys that actually did well. So it's not not the perfect way of trying to do it. Next slide. So this is the ultimate question. Can danazol lengthen the telomeres and reverse MDS in a trial that's hopefully not biased? Fahad, you're on.
Thank you, Manoj.
Thank you. Apologies, I was too fast. Thank you very much. And yeah, over to Farhad, please. Thank you.
Lovely. Thank you very much, everybody. And it's a huge pleasure to speak to you, everybody, today. So I'm going to explain the science behind the VBAP side of treatment. So VBAP is 3 drugs: valproate, bezafibrate, and medroxyprogesterone acetate. So don't worry, I will explain what they all are in a minute. Next slide. So repurposing, redeployment really just means exactly as Steve said, is where we take old drugs and we use them in new settings. And there are lots of advantages to this, as Steve mentioned. Next slide. Ooh. Is that it is cheaper. Because we're not developing brand new drugs, we save on a lot of the cost of drug development. For drugs that are already in the pharmacy, we know what their side effects are, so we know who it's safe to give to, how much we can give you, importantly, who can't take those drugs. And we can also think about combination therapies, so we know which drugs are safe to combine together. And in most cases, cancer therapy is based around combination therapies. And an important aspect is that when we do identify repurposed drugs in the laboratory, we can get them into patients and into the clinic much faster compared to sort of the new development way of doing things. Next slide. Now, the starting point for the study is a combination that is called BAP. And there's a lot of history behind BAP, so I'm not going to go into that, but it is made up of 2 drugs. On the right, we have bezafibrate, which is used to control used to be used to control your cholesterol. Nowadays, everybody takes statins, but before statins, people used to take fibrates. So bezafibrate has been around for a very long time. We know its safety profile, and we know that it's very safe to give. The second drug, so the bez is the B part. The second drug is medroxyprogesterone acetate, or Provera is its name. And it's in fact a contraceptive pill. And it is also used in the treatment of breast cancer. It is a hormone. So the combination of bez, which is B, and P, which is Provera, is called BAP. And these drugs formed the basis of a lot of studies that we did in the laboratory, which I'm not going to go into today. But if anybody is very interested, then I'm happy to talk after the meeting today. Next slide. These, as I said, are very available. They're very cheap. They're available in the clinic, and we know their toxicities. They're pretty much safe to give. Next slide. Now, what we did in the laboratory was, and this is a standard profile, we take cells, and cells are basically your blood cells, and we can have 2 sources of them. We have something called cell lines. These are cells that are growing in the laboratory for a long time, and these tend to be leukemia cell lines. Or we can take patient samples, so this could be blood and bone marrow, and we take those cells and we put them into containers, and I've got here little plastic bottles called flasks, and we treat them with various different drugs. Here I've said control. You have to have a control because you need to know what happens if you don't have drug present. And then we have BES, we have MPA, and we have the combination of BAP. And then what we do is we look at the effect of the drugs on the cells. And so we can look at the morphology. So what do the cells look like? That tells us a lot. We can look at the viability. Are the cells alive or are they dead? And we can also look at the mechanism of how the drug may be working. So those are what we call mechanism of action studies. Next slide. Now, what we've got here on the left-hand side is looking at the viability. So 100% on the vertical axis means that everything is alive. And for what we've got here are 5 different cell lines: HL60, U937, MB4. These are all leukemia cells that were established from different patients many, many years ago, and we could grow them in the laboratory. And they were treated with either control or MPA or BES or the combination of BAP. And we can see that the bar, which is the BAP bar, is the lowest. What that tells us is that the vast majority of the tumor cells have died when we treated them with BAP. On the right-hand side, we've got some pictures of some bone marrow samples taken from leukemia patients. And the control is what the normal healthy leukemia cells look like. So these are alive. And then on the back side, we can see, next slide, we can see that the red arrow, that's fine. Everything is pretty much dead in the treatment with the BAP. Exactly there. So those are dead cells. And we can see that when we look down the microscope. The most important thing, though, was that when we took samples, blood and bone marrow from healthy people, the drugs had no effect on those healthy cells. So what that tells us is that these drugs are specifically working against the leukemia cells. And that's not really a surprise, because if you think about it, these drugs have been in circulation for a very long time. And if they were damaging our bone marrows, we would already know about it. Yep, so next slide. Now, I don't want you to look at this in a lot of detail, but basically we did something called mechanism of action studies. We tried to understand how the drugs are working. And what we realized is that the combination of that works through lots of different ways. And that can only be a good thing, because what it tells us is that you're hitting the tumor cells at multiple sites, and the chances are that the tumor cell is less likely to be able to develop resistance if you're not targeting just a single pathway. Next slide. So the mechanisms are, next slide. It is worth noting that that mechanism of action studies can take a very long time, and they don't always benefit patients, because we can get so consumed to trying to understand how drugs work that can often delay getting drugs into the clinic. And so we did write a little review article if anybody's interested about, trying to balance out patient need with mechanism of action studies. Next slide. Now, doing everything in the lab is great, but we need to really know, does it work in patients? So what we took is, the first clinical trial we did was we took BAP, and we took a group of patients, and we took doses of BES and MPA that have been used in patients before. Next slide. And this is a group of 20 patients, median age was 75. 13 out of 20 had a prior and known MDS. One of them was a grade 2 patient. These are very poor prognosis patients. We did not expect them to survive without any treatment. Next slide. And the results from that trial showed us that 11 out of 20 patients took the drugs for long enough and we could evaluate them. Of those 11, 4 of them demonstrated significant hemopoietic improvement. Their blood counts were increased, so their platelets came up, their neutrophils came up, their anemia resolved itself or improved.
You're at 2 minutes.
Another 4 patients showed stable disease for 9 or more weeks or more. And we have 1 patient who was an MDS high-risk patient who survived for a very long time on his treatments. Next slide. We tried to increase the dose of bezafibrate. Next slide. And this was another clinical trial that we did. We took 18 patients and we tried to increase the dose of Bez and MPA. Next slide. But what we found was that the high dose of Bez wasn't tolerated very well. And the main reason is because a lot of our patients have poor kidney function. And the kidneys are very important for dealing with the drugs. So this was our limitation. Next slide. So where do we go next? Of course, we needed to consider how can we improve BAP, but consider it in a patient group who have much better kidney function. Next slide. So we need a drug that enhances the activity of the low-dose BAP, Bez and MPA. Next slide. So we did exactly the same experiment. This time, no, we took BAP and we put it inside these, what we call wells. So this is a plastic dish, and we crossed it with something called a drug library, FMC. Next slide. FMC basically just means that the library is called after the 3 people who designed it, Farhat, me, Mark, and Chris. And this is 100 drugs which we know are good, safe to use. And we looked to see which drug enhanced the activity of BAP. Next slide. What we found was that valproate, which is used to treat epilepsy, actually improved the effect and activity of low-dose BAP. So on the left, we have again another graph where 100% means everything is alive. And the VBAP, you can see, has got the lowest bar compared to the other treatments. And these are samples taken from patient bone marrows. On the right, we can see that normal healthy bone marrows are not affected at all. So we would not expect to see any toxicity against normal healthy cells in this context. Next slide. So how does it work? Next slide. We have lots of stress and cells experience stress as well, and drugs and chemotherapy can induce stress on cells. Next slide. And one of the types of stress that our cells can experience is called oxidative stress. It's a form of reactive oxygen. And we have a very special pathway that repairs and protects us against oxidative stress. If we don't repair it, that pathway, so the pathway will get activated, so you will either repair it or you will sustain some damage to the cells, or the cells will die. Next slides. And what we showed was that bezafibrate, Bez and BAP induce lots of oxidative stress. So on the right, you can see the grey is untreated cells. So we gave the cells a fluorescent probe, a dye, and the dye only fluoresces when there's lots of oxidative stress. And we can see that Bez and BAP and MPA induce that. So when there's a shift to the right, it means we're getting lots of oxidative stress. Next slide. So when you have lots of Bez, you get lots of oxidative stress, and you see lots of cell death. Next slide. But the response is very dose dependent. So when we put less Bez in, you get less oxidative stress and you get less cell death. Next slide. So what we discovered from a lot of work is that what Bez induces oxidative stress. Next slide. That switches on the, back up, one slide. That switches on the NERV2 antioxidant, this protective pathway. And what that does is that brings that oxidative stress under control. Next slide. What we discovered is that valproate actually stops that NERV2. And now the oxidative stress accumulates in the cells. Next slide. And the cells die. So that's the mechanism that we know that these drugs are working by. What's most important, though, is that the tumor cells are nice and healthy. Sorry, the tumor cells are dying, but not the healthy cells. The healthy cells do survive, and they're very good. Carry on. Next slide. So what we know is that each of those individual drugs is safe. We know that BAP, when we used it in patients, improved the hematopoiesis. So we saw improved counts, blood counts in those patients. And we've shown from the laboratory that the valproate is able to give us enhanced VAP activity. So that's how we came up with a combination of VBAP. And so if anybody's interested in more details, and of course we'd be more than happy to talk about it. But thank you for your time today. Oh, this is very important slide. There's a lot of people who do this work, and I've listed some of those people here.
Absolutely. Thank you so much. Thank you. Right. So now we come to the question and answer session, and you've seen that there's been quite a few questions in the chat.
Someone was asking about EPO and what happens if they're still on EPO, or then if it fails. And I just, to highlight that EPO is a standard of care. If you're eligible for EPO, you can have EPO, and like most medications, that can continue as long as you're tolerating it and as long as you're getting benefit from it. There's no sort of fixed duration of EPO. The question also said, how will it become apparent when I fail EPO? And I think Manoj answered this in as well, is you'll become anemic, and you may then develop or redevelop a requirement for transfusions, and that would become apparent that the EPO is failing. Although we do increase the dose of EPO to try and continue getting that response, it does become, for many patients, it will stop at some point, and then at that point you provisionally be eligible for repair at that juncture.
Do you want me to talk about the liver function, because that's been a bit that's come up a couple of times, I think?
I think that would be good.
And I can talk a little bit about iron in that respect as well. So as you get older, there are all sorts of reasons why your liver might not work quite so well. For MDS patients, yes, there is this issue about, if you're transfusion dependent, whether the iron overload that happens from transfusions might potentially cause problems with your liver. You have to have quite a lot of transfusions for that. And there are drugs available now, and certainly the recommendation from the British Society of Haematology guidelines is that for those patients who are on regular transfusions, to consider, if you've had enough of them, and depending on what your iron level is, whether you should have what are called iron chelation agents. And there's a tablet. There are also injections, which are not quite so straightforward. They're not necessarily easy to take. They do have side effects. They're not appropriate for everybody, but it's something to certainly consider. And you know, for example, the tablets cause problems with the kidneys and various things like that. As far as going into the trial is concerned, because of the drugs and the way they work, and because of the potential problems with the liver, we've said we've excluded patients who've got abnormalities in their liver function. Now, if those abnormalities are sort of fluctuating, or they can be normal, then you can probably get in if they're normal during your screening. But you know, we have to be very wary of the fact that we know these drugs can potentially cause problems, and therefore we're erring on the side of caution, particularly at the beginning. It may be possible to give these things, we just don't know at this point in time. But for the time being, if you've got abnormal liver function, I'm afraid we can't let you in. And if it is due to iron overload, or it's thought that it is due to iron overload, where there is a potential treatment there in terms of iron chelation. But as I said, it's not necessarily for everybody. It can cause, there are potential problems, but it's worth discussing perhaps with your consultant.
There's a couple of questions that just appeared at the bottom, Sophie, if you,
Yeah.
I'm happy to. So one is from Anne. Is Repair MDS suitable for patients with CMML? Unfortunately, it's not. CMML is a myeloproliferative myelodysplastic crossover disorder, so unfortunately you cannot participate, but there are clinical trials in that field as well. One run by a colleague who's part of the wider TMG. So unfortunately, you're not eligible for repair, but there may be other trials you're eligible for. And then how long does EPO typically last for? It's usually sort of measured more in months. It's about 24 months, 18 months, that's a sort of median, but responses are very variable. Some people get brief responses and then it tails away rapidly. Other people can go on for quite a few years. It's quite variable. And then from May Garden, at what point would you go for the trial once EPO has failed? At that point, once it's deemed that you're either unsuitable for EPO, you've been on EPO and you haven't responded, or you've been on EPO and it starts to fail, that sort of dovetails with then you becoming anemic and requiring transfusions. It's at that point that you would be eminently eligible for repair, providing all the other you meet all the other inclusion/exclusion criteria. Is there any specific trials for younger people with MDS? I don't know. I don't know if Manoj wants to comment on that.
Not specifically younger patients. No, I mean median age is higher, but I mean the most of the trials, it must be said, would say over the age of 18. They wouldn't sort of say that you're excluded. So there is no lower, apart from pediatric.
Although
trials,
we don't accept ladies of childbearing age, do we, in repair?
In repair, we have that issue, but there are other for studies in general in MDS, it wouldn't be limited. There was a few questions about, I saw at least one question about where we open and why we're not open in certain centres, and Beth might want to comment on this afterwards as well. But we're trying to open in as many places as we can. We've sort of scoped out places that would like to open. That's very much how we've done it, and places that have been very good in the past at recruiting to clinical trials. It's kind of how we've tackled it. If you know of hospitals that are wanting to open it, if your consultant wants to open a trial in MDS, we'd be really keen to hear from them. And we would happily make contact with them and see whether they can open. So we're trying to aim for about 30 sites in total. We'll need that many to try and get enough patients in. So yes, please do let us know if your hospital is willing to open the trial.
Yes, on that point, I think I would highlight that today's meeting is very much about alerting you to the existence of the trial and to invite you to discuss the trial with your consultant and to make you aware of the possibilities. So always do make sure that you discuss clinical trials with your consultant, regardless of your situation. That's what we always aim for within the patient group, to have that conversation on a regular basis, because new trials come up all of the time, and these might be active treatment trials or monitoring trials as well, which are equally important. So there might be one that is relevant for you. So always ask your consultant about those.
There's a question on low platelets and bleeding, which I can try and tackle. I'm going to be a bit careful. I don't want to talk directly about your case, but I'll talk a little bit more in generality. So I didn't have time to expand on that slide, but in general, if you're bleeding and you've got low platelets or not functioning platelets, it's the other thing that can happen with MDS, then we would give platelet transfusions for that acute episode. If you keep getting problems, then we try and put patients, often we'll put patients on tranexamic acid. So these are tablets you can take anything from once to about 4 times a day. You can also get mouthwashes for patients that get problems with bleeding in their mouth as well. So that can be quite useful from that perspective. And then for some patients, and it's kind of new as far as the guidelines came out now just over about a year and a half ago, and we've given the edict that actually using these drugs called these TPO agonists might be quite useful. The evidence for this has been accumulating over several years. There was a scare at one stage about whether it might actually cause patients to progress. That scare has kind of been eliminated. We don't think that anymore. So we're happy to use them. These are drugs that are mostly used in a condition called ITP, or idiopathic thrombocytopenia. And they're, from that perspective, the NHS has said, yes, you can use those in ITP. Whilst we as a hematologist in the UK have said, yes, we think this would be really useful in MDS, we haven't had the say-so from the NHS itself to say, or from NICE to say that we can use these. So sometimes it might be quite difficult to get hold of these, but we do know they can be quite useful, and they can reduce the amount of bleeding that patients get. That's probably, there are other, when you've got other complications, it does definitely get more difficult to try and treat these things though. You've got other conditions associated, and the complications, and trying to do something about the bleeding can be more complicated and difficult.
Thank you, Manoj.
Just another question, Sophie, if okay, from another Stephen. He was just asking a very practical question: how long is the trial open for? As the counts aren't bad enough to participate, but might be in the next 18 months or so. Well, we currently predicated, I'm looking at Beth here, to be open for another 18 months to active recruitment, but that may well change as the trial evolves. So it could be that it's open longer than that, could even be that it's open shorter than that. But as things currently stand, it's I think August of next year or summer of next year, but that almost certainly will alter.
And if
we will, of course,
I mean, it's a big if we get a positive from this, then we will be looking to extend things.
Yeah, and fold into a subsequent trial, as we alluded to in one of the talks.
Yeah, I think we were mentioned on one slide that a possibility of a phase 3 trial anyway. But we will update on the trial regularly, obviously, as we have done from the start, since we're the official PPI body for the trial. There will be continuous information on the progression and the different stages of Repair MDS.
Sorry, Sophie, there was one more question. Apologies, I don't think I replied it to everyone. It was just about why the trial isn't blinded. So just from so I just said ideally we should, all investigational medicinal product trials should be blinded in an ideal world, as that sort of significantly improves the scientific power of the results we get, and it eliminates bias from us as clinicians and patients. But why isn't it in Repair? Blinding very significantly increases the cost of a trial and the complexity of the trial at all levels, and that has to be weighed against the other competing demands in the trial. And also in our trial, our endpoint is hematological improvement, which is a hard endpoint based on blood transfusions and your blood counts. It's not a subjective endpoint such as mood or tiredness or lethargy, although we're assessing those things in quality of life. That's not the primary endpoint. So that's why for Repair we haven't blinded it, or that was discussed at the point of setup. And also we're comparing back to individual patients from that baseline assessment period. Again, the blinding loses some of its power, which is incredibly important in other trials.
Steve, could you be able to just answer that question about cytopenias and the range in which we would get patients in the trial?
As it
just reposted it.
Okay. As in what levels, or fixed range or fluctuating?
We don't have fixed levels really, do we?
No. Well, we'd average it out over that baseline assessment period. We would average out your whichever the cytopenia it was that was triggering for your inclusion into the trial. So that would be averaged out. I see Beth flicking through a protocol. I have a copy of my paper protocol with me too, following Beth's good example. So yeah, so it's less than 100 for hemoglobin, less than platelets, or less than 1. In the protocol, we actually refer to it as mean count. So if you are fluctuating in that baseline assessment period, your mean level. But I mean, the nature of MDS is, unfortunately, it's often progressive. So although there may be some fluctuation over time, it will be apparent that your cytopenia becomes more significant and you'd be clearly eligible for the trial there. I hope that answers the query.
Is that okay? I think it was Jamie Lee that was asking.
Yeah.
The thumbs up, so that's good.
Okay.
Emma has a question about predisposition. So it's very much going into the study is very much about you and what disease you've got. There will be very rare cases, they do exist. I've got an interest in this. Patients who have familial MDS, but I mean, they are incredibly rare. But it's very much dependent on what your disease is rather than having a predisposition. So if you meet the criteria, then you'll be able to go in. As Steve said earlier, MDS-MPN is a different kind of disease, and there are other trials available, but Repair isn't taking them. But there is a trial, for example, called AMO, which is run by Dan Wiseman's, being run by the University of Birmingham, which might be a potential, but I can only say might.
If everybody's fairly happy with the answers so far, we can maybe move to the next stage in the meeting, which is a bit of a discussion around Repair MDS. And so this meeting is as much for you as patients and carers, but also for the team who are very interested in your feedback, in any constructive criticism, any queries you have as patients entering a potential trial and things like that. So, and we want to start this just to put things in perspective a little bit, put a few questions on the screen for you to think about, and have this open discussion with everybody. So we basically want to know what kind of worries patients have when they go into a clinical trial. Is it that you're worried that it's not going to work? Is it not knowing what the side effects might be, the added visits, the tests are you doing, anything else? And whether there's likely to be some side effects, as almost all drugs have them, something that you would be prepared, if side effects would be something you prepared for, but if you felt they were not so severe, would you rather stop a trial and a treatment rather than put up with any side effects, what other information you would need, and whether you'd consider joining Repair MDS. So I don't know if I've jumped the gun here, Steve, and impersonated you, but feel free to take over.
Fine. Yeah, I mean, entering, having never entered into a clinical trial myself, but having entered lots and lots of patients over many years into clinical trials, there's hopes and fears in sort of equal measure. I mean, some of which we touched about. I mean, the very fact we have a trial means that we haven't fully answered the question sort of posed in front of us. We don't know. We can have sort of earlier evidence that our interventions may be of benefit and may be well tolerated, but if we knew with certainty, then we wouldn't require the trial itself. All investigational medicinal product trials, you're always asking those two things about efficacy, is it working, is it doing what you want it to do, and tolerability, is the patient tolerating that treatment, what side effects are there. As has been mentioned, pretty much any medication has a side effect profile, and that's an equal important part of assessing matters. Stan, I think there's a hand up. Fire away.
Yeah, the added visits and tests that need doing, that was a major concern for me, because I've got the low platelets. They did a bone marrow test, and I noticed that that's included in your setup for the trials. When I had the bone marrow test, they put a plaster over it. This was done in King's College, and of course it's behind you, so I didn't know anything about it. I got on the train, and it wasn't until I stood up to get off the train again an hour later that I noticed that the seat was covered in blood. And it actually took 2 weeks to stop that bleeding. So it's important that the type of MDS is known, which lineage it is, and that people are advised on how to manage some of these tests before they've gone into,
Yeah, well, I'm sorry that happened to you, Stan. I mean, that's we do the vast majority of bone marrow tests we do are outside of a clinical trial. It's part of standard of care. To make a diagnosis of myelodysplasia, whether you're in or out of a clinical trial, you need to do a bone marrow test. Any procedure where you break the skin, you can get bleeding. Or infection.
I'm just saying it's important that you make people aware and check up which lineage and so forth to manage expectations when people are coming into the trials, that's all. Sure.
I mean, you know, many patients who have myelodysplasia have low platelets. Sometimes that's the dominant feature of their disease. And we're often, because of the nature of hematological disease, when we're doing bone marrows, we're often doing them on patients with profoundly low platelets or, you know, other coagulopathies as well. And it's part of your, you know, professional responsibility, whether you're in a trial or not, to ensure that you undertake that procedure safely and properly, and the post-procedure care is adequate. And sometimes that can mean extra supportive care. But yeah, I mean, within the trial, that first one, the first is, we need that first bone marrow, because we need to establish, do you definitely have MDS, because it may not have been proven on a bone marrow initially, and do you if it was previously proven, things can change with time. The IPSSR score can change, so we need to prove you've still got MDS, and we need to confirm your IPSSR is appropriate for the trial. The second two marrows in the trial, they don't require trophine, and that's the component of a bone marrow you might bleed more from. That's the sort of biopsy component, and it is optional. No one can make you do anything you don't want to do, whether you're in a trial or not. But that is formally optional within in the trial in terms of the bolt-on science aspect of that. But yeah, we do ask for a bone marrow at 6 months and 12 months, and like any procedure, it should be done, you know, appropriately and with consideration.
Thank you, Steve. I think just for interest's sake, I've just shared the poll that we did at the beginning, just to get an idea of people's intentions or situation at the moment. So we've got roughly half the people who are interested in joining a trial generally. Only one not at all. Some have concerns, some don't know. Nobody's on a trial, interestingly enough, right now.
Okay.
And we have just over half.
I think that's something to emphasize, Sophie. You know, this is a major area of unmet need. I mean, you know, within, you know, clinical hematology, we've made massive, enormous strides in some disease areas, you know, revolutionized in recent years how we treat and manage some patients. And unfortunately, MDS, and in particular low-risk MDS, is not an area where we've managed to do that. Our treatment hasn't evolved to any near the same extent as it has in other aspects of hematology and broader medicine. And clinical trials are the way, you know, we try and advance that, and repair is a small but important part of that. Sorry, Sophie, I got in the way of your poll train.
No. It's a very important point, Steve. And equally, I'm always interested in how much patients discuss clinical trials, as I mentioned earlier on, with their consultant. And so this is very clear that out of the people attending today, half of them have never discussed a clinical trial with their consultant. A few said, there's no opportunity, but nobody said that it's no time or no interest, which is also very interesting. And just for information, also just over a third are not at specialist centers, but a lot of people are just under half at a specialist center. So there's lots of interesting conclusions to make from that as well. But I really want to emphasize the drive that patients really can just go in there and discuss it with their consultant, even if their consultant does not mention it at any point. Jamie, you've got your hand up as well. Please feel free.
Yeah, I just wanted to say on that point that I do discuss it quite often, actually, with my consultant, and I'm always quite shut down in sort of exploring it as an option. And yeah, that for me is interesting because, whilst I'm not at cytopenia either at 100 or under, it is there or thereabouts, and it's fluctuating around that area. So that should be a conversation. Surely I need to open up again at the next appointment. And what argument do I have to take that counters it being kind of, okay, you're not there yet, which is fine. If that's the case, then, long may that continue. But obviously this is interesting science and research, and you need participants that are interested, and I have.
Just to answer your question about whether this, if you were going to trial, would this be a lifetime thing? The trial's only a year. But if it works, clearly we'd like patients to be on it long term. But there is a question there. The one aspect that makes that a bit more feasible is that these drugs are readily available, or theoretically available, because they're licensed drugs. So that makes it a little easier from that aspect. So that might make it possible. But we'll have to see what happens after a year.
Yeah, so it's not just, I guess at the end of that year, really, you're in a position where actually you were, if you hadn't have been on the trial. That's what I've kind of, I guess, taken from the trial itself and what the drugs actually do.
It'll be a few years before we get answers.
Yeah.
Well, it'll be a few years before we get answers, and obviously we'll be publishing. But if it's positive, then obviously we'll put it out there.
Thank you. I see Richard has his hands up, and I also see a quick question in the chat about luspatercept. I can quickly answer luspatercept question. Now it's basically the manufacturer, Bristol Myers Squibb, has declined submitting for health technology appraisal at NICE, full stop. They've only submitted in a few other countries in Europe, but just a handful. So this is a decision that they've made at global level. And it may be revised at some point, but not for the time being. And one of the things we do at MDS UK is advocate on behalf of the patients to change this situation as much as possible. So that's the short answer. Maybe Manoj or Steve, you want to say how good or bad luspatercept is?
It works in a specific subtype of MDS. So these are the ones with the ring sideroblast or SF, and they have the mutation SF3B1, which somebody mentioned in the chat. So those are the ones that you would directly treat. There is a study, which I kind of alluded to, called COMMANDS, which is opened in just a few places. I'm not sure whether it's still open that much. I think it is open in Bridget, probably only 2 or 3 places in the UK, not much more than that, which is a randomized trial between EPO versus having luspatercept. I think that's not just for patients who are into the bus, but it's not a study I know well because I'm not directly involved.
It's parenteral, isn't it? So
yeah, it's an IV drip.
It's an injectable. Yeah.
I'm not quite sure how often, once a week, or I'm not entirely sure.
Anyway, we have lots of information on the website on luspatercept, so I just wanted to tackle that question quickly. Shall we move to Richard, who has his hand up?
Yeah, hello. I just out of curiosity, I think the first of the trials was aimed at repairing telomeres. I just sort of wondering, that is that not sort of possibly a miracle drug that may cure hundreds of diseases, and possibly be given to sort of reduce the effects of old age on people?
Danazol, as I kind of alluded to, has been around for, well, since the early 60s. And it has been used in a lot of patients, particularly in gynecology, because it's basically an androgen. It's kind of a testosterone kind of analog. It hasn't done it there. It's acting in very specific ways. It doesn't it doesn't stop aging in all your cells. So I don't think it's probably the answer. There are potential ways of trying to look at that and trying to do things, and there are people interested in those kind of things. I'm not an expert on aging, so I wouldn't pretend to be able to know anything in detail about that. But that is something that people are looking at, must be said. But yeah, that's a different area. Let's put it that way.
Okay, thank you.
I can see a question. There's one other question from Trevor about any studies on MDS patients' hormone levels to see whether some sort of HRT may help with red blood cell production.
Yeah, I'll take that. And there's also Rebecca with her hand up after that.
Yeah, exactly.
I'll just take on the Danazol one. The answer, it's not to do, the way Danazol works is not to do with the way it works as a hormone, even though it is a hormone. So we don't think other HRT drug, other estrogens or other sort of hormones in terms of sex steroids would have an impact. Having said which, hydroxyprogesterone is also a sex steroid as well. And so, but we think that might be working in a very different way. Whether there's a connection there or not is to be determined. But as Farhat alluded to, we think there are other mechanisms quite possibly there.
Thank you, Manoj. I hope that answers the question. And if I can ask Rebecca with her hands up.
Thank you. This is the first time I've ever joined one of these, and just really summarise potted history. 2011, diagnosed, then thought wasn't, went to Leeds, bone marrow biopsy in September and confirmed yes. It's the first time I've ever become involved in anything like this. A lot of food for thought, and just been able to connect with people and loads of questions. I actually do work in the NHS, so loads of questions on top of that as well. Distangling my work professional role and my personal role. It's fascinating, a lot to think about, and just thank you very much for this today. It's been really, really helpful. Thank you for all the work that you're doing. And it's a bit strange being on the other side of the dinner table sometimes, but there we go. Thank you very much. A lot for me to consider and think about.
You're very welcome, Rebecca, and I hope you'll join many more of our meetings and use more of our services as well. There's a big community, as the faces and of the people on the call today show. It's a very lovely, warm, tight-knit community that really helps and supports each other. So check in there with often with us, and just checking on everybody who's still got their videos up and who's still here. I think there's no other particular issues. So indeed, thank you ever so much for everybody's participation, time, efforts, energy, and so on. As a reminder, we will this session is recorded and we will be posting it on the website as soon as possible. Is there anything else from the Repair MDS team that I've forgotten?
Just to say, Sophie, thank you for your, for today in particular, but more generally in your support and assistance and guidance and involvement in getting the trial to this point, because there's always bumps in the road and things to be negotiated and navigated. So thank you for your involvement today and before and into the future.
Yeah, just to emphasize, Sophie and MDS UK have been absolutely integral in getting this trial off the ground, and we've taken the ideas and the feedback from patients through Sophie into the trial, and we hope to continue to do that. So Sophie, we very much want to keep working with you in this and to help recruit the trial as well. So it's really, in general, it's really important to get patients involved, and it's something that we've been bad at as doctors over the last 20-30 years in clinical trials, but I think there's much more emphasis, and we want to keep you involved and get your input. So thank you for attending.